Just published May 1st, 2025, the Society of Vascular Surgery released their new guideline on the management of intermittent claudication, also known as IC. The objective of this guideline is to provide a focused update on the management of IC and to address the use of dual pathway antithrombotic strategies, the role and type of exercise therapy, endovascular interventions for femoral popliteal and infrapopliteal disease, and the identification of specific risk factors that should be incorporated into shared decision-making around revascularization. The GRADE approach was employed to describe the strength of each recommendation and level of certainty of evidence. There are 12 recommendations in these guidelines, so let's get started. In patients with peripheral artery disease, also known as PAD, and IC who have one or more high-risk comorbidities and who are not at high risk for bleeding, the guideline suggests the use of rivaroxaban 2.5 milligrams twice daily in addition to aspirin rather than aspirin alone to reduce the risk of cardiovascular mortality, stroke, and myocardial infarction. This is a weak recommendation with moderate quality of evidence. In patients who have undergone surgical or endovascular interventions for symptomatic PAD, including IC, and who are not at high risk for bleeding, the guideline suggests the use of rivaroxaban 2.5 milligrams twice daily in addition to low-dose aspirin rather than aspirin alone to reduce the risk of cardiovascular mortality, stroke, myocardial infarction, acute limb ischemia, and major amputation from vascular causes. This is a weak recommendation with a moderate quality of evidence. In patients with PAD and IC who do not have high-risk comorbidities, are at elevated bleeding risk, or are otherwise intolerant of dual pathway antithrombotic therapy, the guideline recommends the use of single antiplatelet therapy for long-term prevention of cardiovascular events. This is a strong recommendation with a high quality of evidence. In patients who have undergone endovascular intervention for IC, the guideline suggests the use of dual antiplatelet therapy for at least 1 month rather than single antiplatelet therapy. This is a weak recommendation with low quality or very low quality of evidence. In patients with IC who have completed a supervised exercise program and or refuse or cannot participate in supervised exercise programs, the guideline recommends a home-based walking program. This is a strong recommendation with a moderate quality of evidence. In patients with 105 IC, the guideline recommends a supervised exercise program consisting of walking a minimum of 3 times per week for at least 12 weeks as first-line therapy. This is a strong recommendation with a high quality of evidence. For patients who have undergone revascularization for IC, the guideline suggests the continued use of exercise therapy post-intervention, whether supervised or home-based. This is a weak recommendation with low quality or very low quality of evidence. In patients who are being considered for revascularization for IC, the guideline recommends that shared decision-making conversations should include each of the following risks and benefits: mortality, major adverse cardiovascular events, major adverse limb events, functional gain, and health-related quality of life anticipated after revascularization. This is a best practice statement. In patients who are being considered for revascularization for IC, the guideline recommends that shared decision-making conversations involve an assessment of individual risk factors known to influence risks and benefits. These include comorbidities, history of prior limb revascularization, anatomic complexity of disease, and procedural strategy. This is a best practice statement. The guideline recommends against performing revascularization in patients with asymptomatic PAD or IC based solely on hemodynamic measurements or imaging findings. There is no evidence to support the use of revascularization for modifying disease progression. This is a strong recommendation with a low quality or very low quality of evidence. In patients with IC and no signs of chronic limb-threatening ischemia, the guideline suggests against the use of infrapopliteal revascularization, either alone or in combination with a more proximal intervention, due to lack of evidence of benefit and potential harm. This is a weak recommendation with a low quality or very low quality of evidence. In patients with IC who are selected for an endovascular intervention to treat ephemeral popliteal disease and have lesions exceeding 5 centimeters in length, the guideline recommends the use of either bare metal stents or drug-eluting devices over plain balloon angioplasty to reduce the risk of restenosis and need for reintervention. This is a strong recommendation with a moderate quality of evidence. And there you have it. Make sure to check out the full guideline and other clinical tools from the Society of Vascular Surgery at guidelinecentral.com.